asked to do hematuria and proteinuria, which is two distinctly separate lectures, so I've mushed them into one. So I have 70 slides, but we'll gloss over a lot of this and hit the high points. So, and just to qualify this talk a little bit, I think we've already done or are going to do the nephritic nephrotic talk where we get into the actual glomerular diseases and talk about them. What I want this to be is what do I do in the clinic or in my office when I find hematuria proteinuria? And I want to demystify it and make it great. Okay, so that's the whole goal here. So we're not really going to get into much about specific diagnoses except most common and show you how benign it actually is. And to advance the slide, I guess I have to click. There. All right. So yeah. Yeah. Oh, I gotta stay over here. All right, I'll stay over here. Well, then I can probably take my mask off, can I? All right. Okay, so I know this seems kind of silly to define hematuria and proteinuria, but you'll see in a minute how important that is. Okay, and we're going to classify it, and then we're going to talk about how you can do a staged evaluation, so you don't have to throw the kitchen sink at these kids. In fact, it's a very minimalist approach, as you'll see. And again, a little bit about the common diagnoses. So let's start with a case, and we're going to do hematuria first. So this is incredibly common, a common referral to our office, but a previously healthy 8-year-old male comes in for their well child exam and has a dipstick, right? And dipsticks are not recommended routinely by the AAP, but every private practice in Columbia dips urines on every kid every year. So they find a lot of stuff that ain't stuff, okay? And I actually, as a nephrologist, like that if you only knew what to do with it when you got it, okay? But this kid has a positive dipstick. The pediatrician doesn't panic, just has him come back a couple times and it's still there. He's still completely asymptomatic, normal physical exam, normal, including blood pressure. And this one gets a UA, which almost never happens. So we get a UA and we see, lo and behold, there are 10 to 20 red cells, nothing else. And so the question is, how would you approach this patient and what are the most likely etiologies? So we'll circle back to this after we talk about hematuria. So what is the definition? Anybody know? Yell it out. How do we define hematuria in kids? What's the number of cells? 5, okay? So first, the presence of red cells, but you have to have more than 5. If you have 4 to 5, you do not have mild hematuria. You are a normal child, okay? So remember that definition. It's really crucial and you'll save a lot of anxiety and stress and money if you just remember that. Of course, hematuria can be gross or macroscopic, meaning the urine is discolored, and that freaks people out for sure. That's probably what's bringing them to your attention versus microscopic, which is more likely found incidentally. And it's helpful to remember that healthy children pee a lot of blood. Okay, so this is seldom anything pathologic, and different things can affect this, as we'll talk about. I always say the reason a dipstick is called a dipstick is because it's a dipstick, okay? And the dipstick for blood in particular is notoriously inaccurate unless it's normal. So dipsticks are exquisitely sensitive, which means there's going to be a tremendously high false positive rate. And I'll give you some unpublished Holloman data. It's not even really data, but the false positive rate for the dipstick for blood, in my experience, is 70%. Huge, right? So a lot of overworking up of kids with hematuria that never had hematuria in the first place. So because of its sensitivity, however, a negative dipstick for blood, you can hang your hat on. It's really useful. Good screening tests because they're sensitive, but beyond that, you have to confirm, okay? All right, so factitious hematuria comes in 2 forms. Heme positive urine without cells is this one. And as you can see, there's 2 clinical scenarios where that happens. And these are not going to be well kids coming into your clinic or your office for a routine checkup, right? They're gonna have symptoms, there's gonna be something going on. So hemoglobinuria or myoglobinuria are worthy of your thought when you have a heme positive urine with no cells. But when you quickly rule these horrible things out by a history and physical, you go with the 70% false positive rule, okay? You do not have to send urine myoglobin, check a CPK, check a CBC, unless there's symptoms or a compelling story to support one of these diagnoses. Kid comes in, excessive cramping from 2-a-day football practices in August in Colombia. Yeah, I might get some labs on that, okay? You can also have discolored urine that's heme negative by way of pigment change in the urine, and that can be dietary, certain drugs. The classic urates of an infant with orangey red discoloration in the diaper is a common example of that in babies. Again, this is usually going to be pretty obvious to you. They're going to come to your attention because of the discolored urine. You're going to dip it in the office and it's heme negative. Okay. All right. So a very common thing to find hematuria. So about 5% of all children will, if you just check all those urines, are going to have some hematuria, and that's real hematuria. But the good news is it goes down significantly as you repeat samples. And that's back to that kind of kids can excrete up to 1 million red blood cells and be completely fine, et cetera. So it is certainly appropriate in a well kid to just have them come back the next week and recheck it, see if it's still there, okay? It's a big part of our referrals, obviously, but over half of our microscopic hematuria referrals never had hematuria. And I will never throw a referring provider under the bus, but a lot of parents get angry at me when I say, I don't think he ever had hematuria. What? I've been worried about this for 2 months. And I was like, your pediatrician was just being careful and wanted to be sure. And then I explained the whole dipstick nature and all that stuff. So always confirm. Let's say it's real. Then you start thinking about, okay, well, is it coming from something I need to worry about, right? And localizing the source of the hematuria is a good thing to sort of classify this in your brain. So kidney bleeding is either going to be glomerular or non-glomerular, which is tubulointerstitial. We'll go over this a little bit more, or urinary tract bleeding. And any part of the system from the tip of the meatus to the deepest nephron can bleed, okay? So it's helpful to kind of think about this when it comes to you pursuing a workup for a kid with hematuria. And some things can help you, but they're not 100%. So classically speaking, kidney bleeding is brown and urinary tract bleeding is red, but that is not 100%. This is just a guide to help you. I will tell you it's more likely to have kidney bleeding be still red than it is to have bladder or urethral bleeding be brown. But just remember that Coke-colored, tea-colored urine should alert you to something intrarenal, okay? Obviously, the presence of other things in the urine raises the pathologic nature of the hematuria and supports this being a kidney problem. So cellular casts, which many of you have heard me say we never see here. I'll show you a picture of one since you've probably never seen it on a UA report here, ever. In 17 years, I've not seen a red cell cast here. But other aspect, proteinuria, the combination of hematuria and proteinuria is always pathologic until proven otherwise. And then dysmorphic red cells is not that clinically useful unless you spin urines in your office and look at them under the microscope. And you'll read that you have to have this phase contrast microscope to be able to tell dysmorphic from eumorphic red cells. That's not really true. If you can see red cells, you can tell. And I'll show you a couple pictures of that. Again, red or pink urine plus minus clots is more suggestive of urinary tract bleeding. And terminal hematuria, which is a terrible name, means I bleed at the end of voiding, not at the end of my life, okay? So the classic story is the 6 to 8 year old male with meatal stenosis who will pee yellow, and then at the end of voiding, out will come some red urine, okay? The other clue to this, by the way, is crooked stream. So I just saw a kid today that was referred for hematuria. It's gross hematuria, and I'm referring him on to urology because I think he's got meatal stenosis. Mom complains that he pees all over the wall or misses the toilet. Now, some boys just do that because they're not paying attention. So that's what terminal hematuria means. You're not going to find anything else. You're not going to find proteinuria, hypertension, any systemic symptoms, and the red cells are eumorphic. So what does that look like? Very smooth-walled red cell membranes. Now, this is a phase contrast microscope image that allows you to see it a little bit easier than a routine spun urine. But all of these red blood cells have nice little smooth membranes. They're uniform in size and shape. That is eumorphic hematuria. And contrast that with dysmorphic red cells where they have little blebs, altered membranes, is supportive of glomerular disease, okay? And I'll show you a picture of why that happens. This is the ever elusive at Prisma Health red cell cast. Red blood cell casts are obviously not sensitive as a test, but are incredibly specific. If you ever see a red cell cast on a UA, you have glomerular disease, period. Glomerulonephritis, okay? The issue, I hate to pick on our lab, but you have to hunt for these. And when you put the urine on a slide and put that coverlet over the slide, the casts go out to the periphery because they're bigger. And if they don't take the 10 to 15 minutes and scour the entire field, they miss it. And many of y'all have been involved with these kids, but we've had 100 post-strep GN kids over the last decade, and not a one has had a red cell. And you know they're there. So I just think this is a super cool picture, but this is showing a red blood cell traversing the glomerular basement membrane in a setting of glomerulonephritis, and you can see how the membrane gets distorted, and that's why by the time they hit the urine cup, they're dysmorphic in appearance. So just kind of a cool picture. All right, we've got hematuria. How do we classify it? We talked a little bit about localization, and this is really kind of a good way to think about it. First of all, transient functional is the we don't know, but it goes away, so we don't care. Okay, to be honest. Now, there are things that can cause that. We'll talk about them, but they're physiologic, exercise, fever, anything that increases catecholamines and blood pressure and all this stuff. If you, as a baseline, can have some red cells in the urine, it stands to reason that there are physiologic circumstances where you might pee a little bit more. And again, it goes away and is of no harm to the patient. The most important designation for you guys on the front lines is this isolated hematuria label. And that basically is like stalwarts previously healthy. That means there simply ain't nothing else. This is a healthy kid, came in for a routine physical, was found to have greater than 5 red blood cells per high-powered field, but has a normal blood pressure, no proteinuria, no symptoms, no compelling family history, no past history of recurrent UTIs or kidney injury, et cetera, et cetera, et cetera. Physical exams normal, review of systems is negative. That's isolated microscopic hematuria. That has a very benign and limited differential. So there's great power in the history and physical when it comes to hematuria. Whether it's isolated or symptomatic, obviously if they come in with dysuria or edema, it's not isolated. But no matter what form it is, it can be gross or it can be microscopic. So you can have completely painless, asymptomatic gross hematuria. Classic would be like an IgA nephropathy that would do that. And it still be labeled as isolated, provided blood pressure is normal, proteinuria, et cetera, et cetera. All right. Just quickly, the problem with etiologies is that every kidney disease known to mankind can cause hematuria. So your differential, if it's pathologic, is all over the place. But you can be confident that if you can attach the isolated label, you're not missing one of these, okay? So glomerular diseases get broken down into proliferative and non-proliferative. And so the proliferative genes of pediatrics are post-infectious, lupus, IgA, and MPGN. There are others, but they're rarer, ANCA disease, anti-GBM disease, so forth. Non-proliferative, FSGS and minimal change disease that we typically think of in terms of nephrotic, right? But they can have some microscopic hematuria. Alport syndrome is a collagen problem, not a proliferative disease. You see the list there. The most important is the benign, idiopathic, benign, familial. That's the most common, okay? If you can attach the isolated label. And just one slide on the nephritic syndrome, just so you have in the back of your mind the 5 components of the nephritic syndrome: hematuria, proteinuria, hypertension, impaired GFR, elevated creatinine, and edema. Okay, so you can quickly rule all of these out, except the GFR issue with the history of physical. So non-glomerular takes us into the vascular compartment or the tubulointerstitial compartment. So infections, ATN, interstitial nephritis, cystic kidney disease, and the one to really remember is hypercalciuria, okay? And if you'll see this in a minute, but if you remember hypercalciuria, and then on the prior slide, benign, idiopathic, benign, familial, you have 95% of isolated microscopic hematuria covered, okay? So you can start to see how your workup is really simple if that's your differential. Of course, be aware of the hematuria risk in sickle cell patients. Yeah, a renal vein thrombosis is not going to walk in your office for an 8-year-old well child check, so you don't really have to worry about that. We see that in the NICU. We see that in our nephrotic population. Again, renovascular hypertension, easy to rule out with a normal blood pressure. The nutcracker syndrome is an entrapment of the renal vein that leads to venous engorgement and ischemia, and you're never going to have that without pain. So it wouldn't be isolated anyway, okay? But just kind of going through some of the causes. Oncologic issues, you do not have to worry about unless they're Wilms tumor age, okay? So we always image kids under 6. For example, that have hematuria for that reason, where we never image kids over 6, okay? Or sickle cell, right? Because of the medullary carcinoma risk that is exquisitely rare, but exquisitely bad. So you don't usually have to worry about that bad category, if you will, and trauma. And, you know, kids can have trauma without really thinking of it in terms of trauma. But again, usually going to have pain, flank pain, and some history, again, whether it's sport related, motor vehicle accident, I crashed my ATV or my motorcycle or whatever. Yeah, if they're comfortable, yeah. And I think they don't always think about it, but yeah, you just get a renal ultrasound and just think, if I'm, you know, preschool or younger, and I document the greater than 5 red cells, I'm always going to do a renal ultrasound. Urinary tract typically is infectious. Remember that cystitis, whether it be bacterial or viral, can give you hematuria. Remember that young boys can get prostatitis as a viral illness. Again, you're going to expect pain, right? You're going to expect some urinary symptoms of dysuria, frequency, urgency, etc. An obstructed urinary tract can bleed because of things being stretched. And so I have seen kids present with hematuria who had a UPJ obstruction that they didn't know they had, and they just did some rough and tumble play with a sibling. But again, you don't have to go imaging every kid. That's just something to think about. Trauma can be extrinsic, like we talked about, or it can be intrinsic. And intrinsic trauma, the classic is a stone. But there are times where the hematuria might be mysterious, and you're going to have to ask some awkward questions. I think it was 8 to 10 years ago, we had an adolescent male here with a weird story of hematuria who ultimately grew a weird organism in the urine, and we asked every question and it was denied. And then we imaged and we found a foreign body in the bladder, and Dr. Arith went in there and took it out, and it was calcified coiled electrical wire that I know started cringing, that he had fed through his urethra. So you all know this as pediatricians, kids do the darndest things. And it's just, again, something to keep in the back of your mind. I actually had a picture of that wire in the cup, but I don't know what happened to it. But it had been there for a while. It was calcified and coiled up. So, all right. So the most common causes of hematuria in well kids. Benign idiopathic because we don't know, but we know it's benign. Benign familial, and those are probably the same condition, so, or could be. Benign familial hematuria is a collagen problem on the distant spectrum of Alport syndrome, right? It's a different chain of collagen. It's autosomal dominant, so the family history is really important. If a parent has been told for years that they have benign hematuria, it's benign familial hematuria, okay? And it is truly benign, okay? But every autosomal dominant condition has to start somewhere, right? So maybe some of these benign idiopathics are the incident case of the family that have the first disorder of collagen. And hypercalciuria, okay, is the most commonly diagnosed semi-pathologic cause of isolated hematuria. The final one is a hypothesis. We wonder if maybe a lot of kids we think do have subclinical post-strep GN, so they never get their tea-colored urine, they never get edematous, they just feel bad with their illness. And we know that post-infectious or post-strep GN, you keep your hematuria for a year or two. So it's possible that we pick these kids up at a well child check. Now, if that's the case, it's going to eventually go away, whereas benign familial hematuria wouldn't go away. So time is your friend in that regard, but we wonder about that. Yes. Right. Right. Yes. All right. So you need not fear hematuria most of the time. Okay. So, you know, unfortunately, as we embark on all this explosion of genetics and we understand some of these benign genetic disorders, particularly when it comes to collagen, there may not be the 100% benign nature to them than we once thought. But you as pediatricians don't have to worry about it, because no kid is ever going to get kidney disease from benign familial or benign idiopathic hematuria in childhood. When they're 50, 60, there's a slightly higher risk of loss of kidney function than we once thought. I choose not to belabor that because there's no point in making mama worry, or if the kid's old enough, making the kid worry. We emphasize the importance of ongoing annual primary care follow-up so you don't miss anything. You know, I hesitate to put history and physical slides in here because you guys know this, and how cliche is it to say everything starts with a good history and physical, but they're in here, and these were mushed together for proteinuria as well. So it's kind of in the center of the talk. But general well-being, birth history, growth, any history of UTIs. And remember, those of you that have worked with me know this, you have to ask this different ways if you really want an accurate answer. So I have learned that I say, has he ever had a bladder, a kidney, or a urinary tract infection? Because people just don't necessarily understand. But that's a relevant history that might uncover obstructive uropathy or something else that leads you down a certain path. Have they ever been admitted for dehydration and had significant kidney injury? Any preceding infection as a prodrome like post-infectious can present, leading up to the diagnosis of the hematuria, trauma history, medications, and diet. And most of the diet stuff, as you'll see in a minute, circles back around to salt. However, there's also the diet of the discolored urine that's heme negative, right? Did they eat a bunch of beets last night, or what have you? Any associated symptoms? Again, your goal with a review of systems, like your goal with a history of physical, is to attach the isolated label, because that makes your life a lot simpler as the frontline clinician. So they should be asymptomatic. If it's gross hematuria, what's the pattern? Is it that terminal hematuria? What color is it? Is it throughout voiding? Systemic symptoms, fever, weight loss, anorexia, fatigue, rash, joint involvement, bloody diarrhea. Usually you're going to get attended to pretty quickly with that. And of course, edema that may not be obvious to you on your exam. So a history of edema is useful. Family history, anybody have hematuria? Anybody have a history of hearing loss at an age younger than would have been expected? If great grandpa lost his hearing at 80 and wears hearing aids, that's probably not relevant. any history of chronic kidney disease or kidney failure, kidney stones, cystic disease, and urinary reflux, which can run in families. Blood pressure is really a critical part of the physical exam for hematuria or proteinuria, but again, we're not going to belabor this because you guys would do a good physical exam. Meatal stenosis, I will admit I'm not that good at it. Sometimes it's obvious. Sometimes these little, preschool or early school age boys will have just a pinpoint meatal opening that will strike you as being small. A lot of meatal stenosis can be internal. And so if it looks normal to you and the pattern fits, let urology see them and decide if they need to be scoped, because they can just dilate that up and the blood goes away and everybody's happy. All right. This was kind of a landmark study for us back in 2005 that empowered nephrologists to take a minimal approach to isolated microscopic hematuria. And Jay Bergstein and his group took almost 350 consecutive school-age kids that had proven hematuria and did the full court press that I was taught to do in fellowship. When I asked my attending why we do all these tests when they always come back normal, she said, because there's an expectation when a kid gets referred that we do more. So you do what you're taught. But now we know that was a waste of money. So the vast majority of kids had no diagnosis. Ultrasound was of little yield. There was not a single positive urine culture if they were asymptomatic. And the only thing found was hypercalciuria of significance, okay? So therefore, your workup, if you can attach the isolated label, should be limited to that. So I don't get blood work on these kids if they usually come in already having had it. I don't image them, okay? We prove there's blood with a UA and we check calcium creatinine ratio and we ask the parents to see their doctor and have their urines checked. That's all we do, okay? So if kids have other tests, it's because they had it before we got our hands on them for the most part. But let's look at a phased workup. So phase 1, again, with isolated, is a good history and physical and a calcium creatinine ratio. The sickle cell screen is kind of not that important in South Carolina unless the kid was born somewhere else and was never screened, and then just take that history and ask about it. There was some data out that looking at a urine microalbumin might be helpful, because in the earliest forms of renal disease, you can have microalbuminuria and no proteinuria. And we're going to talk about microalbumin in a second. We don't do that, okay? But because it's in the literature, I put a question mark by it. I would encourage you not to pursue that if you're confident with your isolated label. Knowing the urine has been checked or having it checked on first degree relatives because of the familial nature of this. If it is a boy and there's zero family history, we just recommend that through routine well child care, they have a hearing screen, which as I understand it happens anyway, okay? And the caveat I'll put to that is if there's more compelling history, then I don't trust the in-office or in-clinic hearing screen, and we recommend a referral to audiology, okay? Because I am sure in a busy office, you will miss mild, high-frequency sensory neural hearing loss on a routine well-child hearing screen. But if there's no family history, that's fine, and we follow the kid. Again, if they're Wilms tumor age, we image, okay? So that's it. That is all the pediatrician has to do. If they're comfortable stopping there, whether it's a phone call to us or not. We are always happy to see these kids, particularly if the parents are super anxious. And sometimes you have to go a little further down the path, right? So phase 2 is when we start looking at blood work. But there has to be a pretty compelling reason to go here. And I kind of included everything, including the basic serologies that we do when we're worried about glomerular disease, imaging in older kids if things aren't really adding up. By the way, gross hematuria, if it's isolated, I never fault anybody for doing a renal ultrasound. Microscopic, we don't do. But gross hematuria, it's probably something to think about. And it's such a painless, relatively inexpensive, non-invasive test. So phase 3 would include more serologies, again, you got to have a good reason for that typically, maybe further imaging, and biopsy is always listed. I don't think in my career I have ever biopsied a kid for hematuria only. Now, if you get to phase 2 and you have to do blood work for whatever reason, this, coat colored urine, maybe blood pressure is a little borderline, maybe there's a little bit of protein. Well, now we're removing the isolated label anyway, and they're hypocomplementemic. Yeah, we may consider that. Okay. So indications for phase 2 would be gross hematuria potentially, the presence of proteinuria, which removes the isolated label, the presence of hypertension, which removes the isolated label, a significant compelling history of Alport syndrome or other inheritable renal diseases in the family. There is also some data out there that is loose that I also added with question mark. Some people feel the duration of hematuria is significant. Some people feel the degree of hematuria is significant. So duration, if you still have this hematuria a year later, there are nephrologists out there who would check renal function panel or BMPR, okay? I don't do that. I see you, and if you're still isolated and well and happy and healthy and growing and thriving, and there's no other clue to any chronic kidney disease, I don't poke them. But just know that's out there. I hate to be vague about something like that, but there's been some studies that look at, say, I started with 10 red cells and a year later I have 50. My likelihood of having something goes up. And I'll tell you, for both of those, when you really dive in to biopsy studies and what was found more often than not, it was IgA nephropathy and Alport syndrome, okay? IgA nephropathy without proteinuria, we don't give a care. We don't treat it. There's a high spontaneous remission rate, so why look for it, okay? Alport syndrome, we can't treat anyway, so unless they get proteinuria and things seem to be moving forward, I don't do phase 2 workup for those either, okay? But that's the rationale that was given in the literature. Oh, you're likely to find IgA disease and Alport syndrome. What are you going to do with it? Nothing. We would biopsy them for fixed proteinuria. As I mentioned at the onset, the combination of hematuria and proteinuria is always pathologic. If they get to that point and have had labs and have an elevated creatinine, they're likely to get a biopsy. Persistent hypocomplementemia beyond 12 weeks, which is the normal resolution of a post-infectious kid, get you a biopsy. And of course, if you've checked an ANA due to symptoms and it's positive and lupus is now surfaced as your number one, any lupus patient with renal involvement gets a biopsy 100% of the time. You are almost never going to have to worry about these things in a healthy school-age kid with isolated hematuria. So since you're going to do less, follow-up is really key. And how we approach these kids is a 6-month follow-up, and then we see them annually thereafter. If the pediatrician ever calls and says, hey, I just saw them for their well child check and they still have 10 red cells and they look great, do you need to see them? My answer would be no, if you're comfortable, okay? But a lot of our punts back to primary care get re-referred, okay? So that's typically our approach, but it would be perfectly fine with us if primary care followed this, if they're comfortable, okay? What typically happens, and the same thing happens with proteinuria, is they get referred, we see them, we say, come back in a year, but they go in for their next year's checkup and they have moderate blood on a dipstick, and the pediatrician says, oh, he's got blood again. Well, maybe not, right? 70% not. Didn't you see nephrology? Oh yeah, but it's been a year. You need to go back. So my note, which said, if you ever find it on the dipstick, do a UA, and if there's 5 or fewer cells, it's normal, don't worry about it, is buried a year ago in the EMR, and it's a busy practice. They just don't take the time to go find it. I think that's just the nature of the beast. So because they get re-referred, we will schedule follow-ups, but we don't have to, okay? Annual BMP for fixed hematuria, guys, is in there, again, because you might find it in the literature. But if the isolated picture has not changed, we don't do that, okay? So know that that's optional. Okay. So just a couple of slides on the explosion of genetics and the classic benign, idiopathic, benign familial hematuria, what has been found now, and how it might not be as benign as once thought. Growing list of causes of this with advances in genetic analysis. And it's generally going to boil down to a collagen problem, this non-muscle myosin heavy chain disorder, complement factor H related protein. You do not have to remember this, and the ever-present IgA. Okay, IgA nephropathy is rare in that it's worldwide the most common glomerular disease. What's rare about it is many things, if you get them when you're young, your outcome is worse because you're going to have it longer. You want IgA nephropathy as a kid. You don't want it as an adult because the spontaneous remission rate is so high in pediatrics. So, and again, these are the genes associated with that. We know Alport syndrome is a bad disease, right? But now we're starting to see, for example, this thin membrane disease, this TBMN, the other chains of collagen being genetically altered, 10 to 15% chance of having end-stage kidney disease in your lifetime. We used to think 0. It's never going to happen in the first 3 decades of life, okay? So who knows where this will go eventually as we identify more and more of these. So prognosis is really excellent. If it's isolated, most of them resolve. It's considered benign in the vast majority of cases. Degree and duration may have some influence, but again, the pathologic findings that you might uncover, you wouldn't necessarily do anything about. So it's just to have in your brain. Gross hematuria, we're more likely to find a reason, but not always nonetheless. And as y'all have experienced, not giving a parent a diagnosis is hard on the parent, but sometimes we just don't know. So I spend a lot of time just reassuring them. And if it's not isolated, right, then it's going to carry a more guarded prognosis depending on the cause. So real quickly, let's talk about hypercalciuria, because every kid you see with greater than 5 red cells per high-powered field is going to get a calcium to creatinine ratio. Okay, and here are the norms, and they change with age. The nice thing about the school age norm is it's the same as proteinuria, 0.2, so you don't have to remember one number, but know that infants and toddlers pee more calcium than school age kids and are still normal. Sometimes we have to confirm with a 24-hour urine, and you're allowed up to 4 milligrams per kilogram per day of calcium excretion and still be normal. Very common, 40% of children with isolated microscopic hematuria might have hypercalciuria, and 50% of kids with stones. So stones and hypercalciuria can go together, but can also be mutually exclusive from one another. Okay, when you find an elevated urine calcium, we go into phase 2 with our workup a little bit. We get a one-time chemistry panel and an ultrasound. The ultrasound is to rule out nephrocalcinosis, and the chemistry panel is not to rule out hyperparathyroidism and hypercalcemia, though you will rule that out. It's to screen for distal RTA, which is associated with hypercalciuria. Okay. Just had a kid the other day in our office with mild hyperparathyroidism and hypercalcemia and kidney stones. Hadn't seen that in a long, long time. Calcium oxalate crystals have this appearance, but you don't really have to worry about that, this hexagonal appearance. We do the ultrasound because we want to be sure we're not dealing with medullary nephrocalcinosis. We want to see if there's a significant stone burden. Obviously, this is a CT scan, but stones that are significant can show up on ultrasound as well. And these suckers hurt. It's not funny, but it's a little bit funny when a kid passes a stone and catches it and sees it, and they'll look at it under a magnifying and they're like, this thing did that to me, right? They're like teeny sand spurs and many times go unnoticed as they pass them. What do we do for it? My former partner in Washington State used to say the solution to the pollution is dilution, and I absolutely love that. And so I use it all the time. But forcing fluids, a dilute urine, decreases the precipitation of calcium oxalate. And you know this, getting kids to drink is tough, particularly water. but it is highly effective. So we push non-calorie fluids, non-caffeinated fluids. It doesn't have to be all water. We don't want caffeine because caffeine's a diuretic, okay? And we restrict their sodium intake. Sodium and calcium excretion are linked in the distal tubule. We're going to walk through a tubule cell for just a few seconds because it's kind of cool in my opinion, and that's all the physiology that we'll talk about. We don't restrict calcium because calcium is healthy and important for bones and growth, okay? Once in a while, you'll find a kid who's a 1.5 gallon milk drinker a day. We'll reel you into the RDA, okay? So, but we don't restrict below the RDA. Thiazide diuretics decrease calcium excretion. So in a kid with fixed hypercalciuria who's having recurrent stones and we think is compliant with the diet, we can put them on hydrochlorothiazide and lower their urinary calcium. And potassium citrate is simply a stone preventer. So again, we're moving from classic idiopathic hypercalciuria with these drugs into kids that are having stones and complications of their hypercalciuria. All right. So a distal tubule cell, right? So, you know, the average sodium intake of adolescents in South Carolina is, I think, 6,000 milligrams a day. And so it's a lot of salt. We live in the Stone Belt, USA, the South. So we eat a lot of salt, we absorb a lot of salt, we filter a lot of salt. More sodium finds its way to this distal tubular cell and revs up this sodium transporter. That means more sodium comes into the cell, okay? Now, it turns out there's a coupled transporter on the other side that's a gradient dependent transporter. So as the sodium level increases in the cell, the drive for this transporter gets inhibited, okay? That leads to an increase in intracellular calcium, which then decreases the impetus to absorb it. So you pee it out, okay? A low sodium diet or hydrochlorothiazide does the reverse of all those steps. And that sodium chloride channel that's involved here is where thiazide diuretics block, okay? So it can be very effective. All right, oh my goodness. Hematuria take-home points. So don't forget the definition. Don't base it on a dipstick. Please don't ever send me anybody from CHOC who's just had a large blood on a dipstick, okay? Isolated microscopic hematuria, we know the definition. There ain't nothing else. And it's not to be feared. It is likely benign. You're gonna screen for hypercalciuria and follow them. So it really is straightforward. So in our case, our 8-year-old who came in with 10 to 20 red cells, how would we approach? We're going to screen the urine calcium. We're going to talk to the parents about getting their urines checked if they haven't seen a doctor in 5 years. We're going to look at a hearing screen routinely with a negative family history, audiologically with a family history, and because it's a boy. And we're going to see them back in 6 months. Be sure they don't have hypertension, proteinuria, and new symptoms that they didn't have at first visit. And then beyond that, we're going to see you yearly. Most likely etiologies, benign idiopathic, benign familial, hypercalciuria. No one has ever succumbed to hematuria, okay? So don't be afraid of it. All right, let's quickly go through proteinuria. Again, this is hard because these are whole talks on their own. The case here is a 14-year-old male comes in for a sports physical. He's asymptomatic. He had 2+ protein on a random urine that was heme negative. History is negative. Blood pressure is normal. He comes back a week later and it's still there. We're going to talk about how you'd approach that patient and the most likely diagnosis. I love medical history. Hippocrates says bubbles floating on the surface of the urine denote affections of the kidneys and that the disease will be long. And what Hippocrates was saying is that proteinuria is bad. Okay. He didn't know that bubbles meant proteinuria, but you know, you've heard this before, right? So a proteinuric urine froths more boys than girls because of the force of the urine hitting the water in the toilet. The barrier to proteinuria, because your blood is full of protein, is really, really efficient. And that barrier is the glomerular capillary wall, and it involves 3 structures: your endothelial cell, the GBM itself, and your epithelial cell or podocyte. And any abnormality in any of those 3 things results in proteinuria. And somebody with a tremendous amount of time on their hands and with a good grant has actually measured Bowman space albumin, and you can see how efficient that barrier is. And seen schematically, one capillary loop in the glomerulus, the podocyte in pink, the GBM in green, the endothelial cell in yellow, and that creates this barrier to proteinuria. Looking at this under electron micrograph, you see the foot processes coming down on the GBM. Here's your endothelial cell. And if you look even closer, these are the foot processes, and they have a little slit diaphragm in between. And it is the podocyte that is the money when it comes to pathologic proteinuria. And I'll tell you, and I shouldn't go off on too many tangents, we're running out of time, but when I was a fellow, there was this argument amongst researchers. There was the endothelial cell camp, the GBM camp, and the podocyte camp. And those poor podocyte scientists were shunned. It was like, that is not anything. It's all going to be in the membrane. And now we've come full circle and we know it's the epithelial cells. So I hope they're all still around because they've been proven right. All right. How do we measure it? The dipstick. Okay. Now the dipstick for protein is still a dipstick, but a negative dipstick for protein you can hang your hat on. Okay. Just like blood. There are times where we have to quantify it. And the gold standard to this day is a 24-hour urine. They're done less because we have the silver standard, which is a random protein to creatinine ratio. And then the serum albumin can serve as a quantifier. So when you have nephrotic syndrome, an albumin of 2 and pitting edema, you do not have to do a protein to creatinine ratio. You do not have to do a 24-hour urine because it don't matter because it's enough to drop your albumin, okay? So the serum albumin can be useful in that setting. Here's what the dipstick tells you, okay? Negative, that's obvious. Trace is negative. Trace of blood or trace of protein does not require any follow-up testing at all. Okay. I'm not going to get into trace ketones in certain settings, but for blood and protein, consider trace negative. 1+ equates to a concentration of 30, and you'll see different labs reporting it either in the number or the plus scale, right? So 1+ is 30, 2+ is 100, 3+ is 300, and 4+ is 1,000. It doesn't matter, it's a screen, okay? So the dipsticks are highly sensitive to albumin, which is the pathologic protein that we're talking about, and that therefore important. Other proteins it's less sensitive to. The main thing to remember about false positives and false negatives in clinical practice is the urine concentration, okay? So if you have a concentration of greater than 1015, 1+ is apt to be false. You're still going to repeat it, okay? 2+ and above is always abnormal no matter what the specific gravity is, but is seldom pathological. Okay, so trace negative, 1+ variable, 2+ and above abnormal. And abnormal does not mean pathologic, as we'll see. All right, so the 24-hour urine is still the gold standard. And I've been fooled many times to this day by protein to creatinine ratios. Okay, so we have to think about this. The issue is it's inconvenient. Kids will forget and flush, and you won't get a complete sample. If they're bedwetters, it's hard, you can't do it. If they're pre-potty trained, you don't want to put a catheter in them for 24 hours. But it's going to give you far more accurate information than a random protein to creatinine ratio ever will. We always add the creatinine, and I've had labs actually draw blood on patients because they thought I wanted a creatinine clearance. I have never ordered a creatinine clearance, okay? The 24-hour urine creatinine serves 2 purposes. It'll allow you to assess the adequacy of the collection because kids lie, okay? They're afraid to tell you they didn't catch every void, that they're in trouble or something. So no, it was a complete collection, but we know what your normal creatinine excretion is, so it guides us there. Secondly, you can calculate a protein to creatinine ratio on a 24-hour urine just as easily as you can on a cup. So moving forward, you can do random ratios and compare to that baseline 24 hours, if that makes sense. So we always include the creatinine with the protein. A split 24-hour urine collection is to diagnose orthostatic proteinuria, and seldom do we get to this point. It's confusing for labs more than it is for families, but it is a 2-jug collection. And there is some normal for recumbent proteinuria. Okay, so if it's kind of equivocal, this is the gold standard test. The problem is labs will see 2 jugs and go, what? And they'll dump one into the other, and we'll get our 24-hour urine, but we won't know the pattern. Okay, so you have to kind of counsel the patients to say, you do know he wants these measured separately, right? And for most kids, the only void that goes in the nighttime collection is the first morning void. Okay, so they kind of collect all day long and stop at bedtime. That goes on ice. And then they pee first thing in the morning in the night jug, and we've got 2 jugs, and we can look at the variation there. Protein to creatinine ratio came along as showing good linear correlation with 24-hour excretion rates and has good norms for us now and is a convenient test. So I don't want to overly poo-poo it, but just remember that it's limited by being a point in time. Anything that's going to affect creatinine in the urine, like muscle mass or decreased kidney function, is going to alter the ratio. And even if you're in that setting, if you're trending, it's a useful test, and it is really easy to collect. All right, we kind of talked about this, the definition on dipstick, 1+ if your spec grab is less than or equal to 1015. Protein to creatinine ratio, school age, again, that magic 0.2, it's 0.25, but if you just remember 0.2, you're good. Babies, toddlers pee more protein like they pee more calcium, so the ratio is higher. And the classic pediatric definition of proteinuria is 100 per meter squared per day. Nephrotic range would be a protein creatinine ratio of 1 or a gram per meter squared per day. But again, if it's nephrotic range, the albumin is low, and you've quantified it with hypoalbuminemia. All right, so isolated proteinuria has the same definition as isolated hematuria. There ain't nothing else. Okay, routine, come in for checkup, 2-3+ protein in the urine. It also is transient and functional category, but it's going to go away and you're not going to worry about it. Pathologic proteinuria can again come from the glomerulus or the tubulointerstitial compartment, but mostly what we're dealing with is benign orthostatic proteinuria in an otherwise well school-age kid, particularly an adolescent, and even more so an athlete. Okay, doesn't have to be though. Functional proteinuria, anything that affects intraglomerular pressure or volume, can lead to a little bit of proteinuria. Again, same sort of setting as hematuria. The reason that congestive heart failure and solitary kidney is up there is because there's hyperfiltering that goes on, and that can lead to some proteinuria. But just know that this is usually transient and functional. So orthostatic proteinuria, no kidney disease known to mankind stops when you climb into bed at night, which gives tremendous power to a first morning urine sample. You simply cannot fool yourself by having a normal first morning urine, okay? It should be incredibly reassuring. It is very common. Some have it for life, some are transient, and there are amazing up to 50-year longitudinal follow-up studies of benign orthostatic proteinuria, and they simply do not develop kidney disease if the pattern stays orthostatic. So lots of good evidence to back you up on the benign nature of orthostatic proteinuria, even if it never goes away. Okay, if you get to the point of quantifying it with a 24-hour urine, the literature will tell you you can have up to 1,500 milligrams of protein and still be benign. In our pediatric world, we seldom see anything above 1,000. If we have above 1,000, we're going to follow you a little more closely and have that biopsy needle kind of hanging out, ready to go. So glomerular causes, again, we're not going to dwell here. This is a talk for another day, and I'm running out of time. So let's just move on. Also common. So you're going to see this in practice. Probably have already seen it in chalk. So the approach, a history and physical, a UA, because you want to look for that elusive cast or a cellular element that might not have shown up on the dipstick. Unlikely to be blood, because I told you how sensitive that was. Okay. And then a first morning urine protein to creatinine ratio. You don't have to jump to the 24-hour. okay? So what we do, because we get a lot of these referrals and all they've had is that 3 o'clock in the afternoon sports physical 3+ protein, we just send them home with a cup, assuming our history and physical has supported the isolated label. And we do a UA and a protein to creatinine ratio on a first morning sample. And I always tell the kid, it doesn't have to be morning. It's the first pee out of bed. If you sleep till noon, pee in the cup at noon, doesn't matter. We want the urine that's gathered in you supine, okay? So the reason we do the protein to creatinine ratio is you're gonna typically get that 1+ concentrated, right? Because they haven't been drinking all night. And you're gonna have to then be brave. I'm gonna assume that's negative because of the concentration. But if you have the protein to creatinine ratio to back you up, you'll know. And if it's normal, have a nice life, or we'll see you in a year. Okay, these kids, benign orthostatic proteinuria kids, also get re-referred to us. So I've given up and I just see them yearly. Okay, but if you're out there and you're comfortable with it, that's fine, just like the hematuria kids. The staged evaluation is going to be very similar, with the nuance being you might do the 24-hour urine to get better quantification. Further imaging could include a DMSA scan. You know, we don't like DMSA scans for pyelo because we think pyelo is a clinical diagnosis and it's a $4,000 test. But if you've got fixed proteinuria with a history of UTIs and maybe a little parenchymal thinning or something on ultrasound, this is a great test to show you a scar. If you see a scar, that's the source of the protein, okay? We are going to move more quickly to a biopsy with proteinuria that's not orthostatic than we would with hematuria ever, okay? Proteinuria is a little more concerning to us than hematuria. So if the proteinuria persists and certainly is non-orthostatic, we're going to move down the workup. I'm shrinking. If you end up quantifying it and it's more than a gram, we're going to consider moving down the workup. If you do the split collection, which you're probably seldom going to ever do, and it's more than the magical 50 per meter squared, then we're going to move further down the workup. And then the young kids, okay, because benign orthostatic proteinuria is typically a condition of adolescence and pre-adolescence. Not that a 6 to 8 year old can't have it. And I will tell you guys, even though I'm trying to emphasize the benign nature of this, is that renal diseases that have proteinuria can start in their infancy with an orthostatic pattern, okay? It's just the overall proteinuria is so little that it kind of goes away when you're not ambulatory. So you may miss something, but trust me, if you'd have diagnosed it at that stage, you wouldn't have done anything about it. And if it turns out to be something, you're going to find it as long as you have established follow-up. So rising proteinuria that's non-orthostatic, renal insufficiency, I mean, this is kind of obvious. These are the things that we would consider a biopsy for. Prognosis is excellent for functional because it goes away, and for orthostatic because it's completely benign as long as it stays orthostatic. If it's pathologic, the prognosis obviously varies by the disease. And then proteinuria is unique because for us, it's a vicious cycle, right? It's a double-edged sword. It represents something. And if it's out of the benign world, even more so, and it causes scarring. So the kidney does not like protein passing through it. So you get in this vicious cycle of scarring. And so this is why if we have a disease that causes proteinuria that doesn't have a treatment like steroids or other drugs, they go on an ACE inhibitor because we want to decrease, we want to ameliorate the proteinuria and minimize the risk of scarring in the kidney from it. So microalbuminuria. We actually have dipsticks in our office that screen for microalbumin. They're not very common, but microalbuminuria, Stallworth is still teaching me things. I don't know if he's on here. If he is, I shouldn't say this. I don't see him anyway. When he was working in my clinic, when I was solo, of course, he told me this as he's teaching me something, but what he did was he called the lab and asked them and got an explanation and then acted like he had known it all along. And this one won't shock any of you, but we both thought, to be honest, that microalbumin by its name was a smaller protein and therefore showed up earlier. It is not. It is still albumin. The micro is a dilutional thing. So if you order a microalbuminuria, they dilute the urine down so they detect more minimal amounts. Clinically, it still serves the same purpose. It's the earliest finding in chronic kidney disease. It shows up before proteinuria shows up. So it doesn't change its usefulness, but it is a dilutional thing. And it's linked to other comorbidities. So certainly in our obese population, those that have microalbuminuria versus those that don't are at a higher risk for cardiovascular disease. So it's something that we screen for quite a bit. And certainly in our chronic kidney disease population or in other conditions like diabetes, if you've been to endocrine, you know that those diabetics get the endocrinologist screen their microalbumin all the time. You want to catch it at the earliest level. And we may, depending on the diagnosis, use ACE inhibition for microalbuminuria before you go on to get over proteinuria. There is never a time, if you have fixed proteinuria, that you ever need to bother with a urine microalbumin because that ship has sailed, right? So once you move on down the path and have proteinuria, there's no need to check microalbumin. It's a sequence. And it's very easy to do a microalbumin to creatinine ratio, just like a protein to creatinine ratio. They try to confuse you because the norms are different because the units are different. So a protein to creatinine ratio and calcium to creatinine ratio are straight up milligram to milligram. Okay, units are the same. Microalbumin is milligram per gram creatinine, and the normal is less than 30. Okay, and LabCorp, who tries to make your life miserable, will throw all kind of units, and you got to know your metric system. Okay, so you may have to convert to be sure you're in that milligram to gram creatinine. So just be aware of those units is all. So we quantify dipstick positive proteinuria with a random ratio, or we consider going on to the gold standard 24-hour urine. Isolated proteinuria is the same definition as isolated hematuria. There simply isn't anything else, and it's a healthy kid. And when that's the case, we typically see benign orthostatic proteinuria as the most common cause. Non-orthostatic isolated proteinuria, we worry about. We don't worry about hematuria, okay? We worry a little bit more about proteinuria. So in at-risk patients, consider an annual screening of microalbumin to creatinine ratio. And like everything else, long-term follow-up is the key. So back to our case. 14-year-old comes in, healthy kid, has proteinuria, 2+. We do a UA, so we prove there's no hematuria, pyuria, or casts present. How would you approach this patient? What are you going to do? When? Right, firstborn, okay, or first get out of bed, right? Send them home with a cup, send them home with an order, and screen that first urine of the day. Most likely diagnosis, benign orthostatic proteinuria. Okay, sorry for the rapid fire finish. I was 4 minutes late. So any questions? It's Dr. Carney's fault for asking me to do 2 talks in 1 hour. All right, guys.
Thanks, Dr. Holloman.
You bet.